So Dr. Brij is going to deliver our next talk, that is PCOS across lifespan. One should know the spectrum of disease. I welcome Dr. Brij, please.
Thank you so much, APR, and our newly formed team of Endocrine Society of Rajkot, Dr. Nilesh Detroja sir, our head, for giving me this opportunity on this August platform. To start with, everyone would be skeptical. Since this is a physician audience, we are not expected to have a talk on PCOS basically. So I am very confident that within next 15-20 minutes, we'll have reasons sufficient enough to make sure that PCOS is a physician domain. Of course, it's a core endocrine domain, but had it been a gynec audience, it would have been better. But let's see, we'll start our talk. So PCOS is polycystic ovarian syndrome. It is defined by mainly three basic pathophysiologies. One is anovulation, second is hyperandrogenism, and polycystic ovarian morphology. This is time tested. It has been there since a very long time, and it is shown by WHO that almost 3.4% of women worldwide are affected by PCOS. So, and there is a heterogeneity in its morphology as well as its clinical presentation. The etiology is unknown. Mainly it is having a strong genetic background as well as familial, environmental and other dietary influences which leads to the development of PCOS. And the treatment is mainly symptom oriented, but it is personalized. We'll go brief about treatment also in the coming slides. So mainly the main pathophysiology surrounding PCOS is insulin resistance. So as we know that insulin resistance drives all parameters of metabolic syndrome. Similarly, PCOS is now well recognized as a component of metabolic syndrome, and the main hormone driving the clinical manifestations of PCOS is increased level of testosterone, which causes various pathologic defects in terms of alopecia or hirsutism, as well as the ovulatory disturbances and menstrual irregularities. So the clinical features as we discussed are acne or hirsutism or alopecia or polycystic ovarian on the ultrasound, as well as weight gain or obesity. So conventionally it is said to be a disease of reproductive age group. So it is most common disorder of women in the reproductive age group, about 8 to 13%. Prevalence in India is variable right from 3% to 20%. The classical criteria which describe PCOS, if you go and ask a gynecologist, they'll say in terms of Rotterdam criteria. So they need 2 out of 3 criteria to be satisfied to be called it as PCOS, that is chronic presence of oligoanovulation, hyperandrogenism and polycystic ovarian morphology. However, there can be secondary causes of PCOS also, which has to be looked at, that is thyroid dysfunction, hyperprolactinemia, non-classical CAH, adrenal or ovarian tumor, Cushing syndrome or acromegaly. These are PCOS mimics. So these are the diagnostic clue. On ultrasound you can get a classical string of pearl appearance which with increased ovarian volume and multiple small follicles. Elevated LH to FSH ratio, typically more than 2:1. The total testosterone level in your biochemistry will be more than 60 ng per dl, or free testosterone more than 0.75 ng per dl. And of course, we will have acanthosis and other clinical markers of insulin resistance. Lab confirmation of insulin resistance is not required for diagnosis. Now, my topic for today is why PCOS is considered as a lifespan disorder. So PCOS is more than just irregular periods and infertility. It is a complex endocrine, metabolic and psychological syndrome, and symptoms evolve with the age of the patient and risk persists lifelong. So it is essentially a lifelong disorder, and it begins in early in childhood or even in utero, and it peaks in the reproductive years, and it unmasks in later in life in terms of other components of metabolic syndrome like MASLD, type 2 diabetes or cardiovascular disease. So for a physician, it is important to know that PCOS puts women at risk for other disorders as well. Up to 50% women with PCOS develop diabetes or pre-diabetes before the age of 40. They have got 5 to 7 times higher risk of myocardial infarction compared to those without PCOS. They are at increased risk of hypertension, dyslipidemia, sleep disorders like obstructive sleep apnea, as well as mental health related concerns like anxiety and depression. And due to excess of unopposed estrogen, they are at an increased risk of endometrial cancer also. So now slowly, I'm very sure you must be relating that these are the common presentations we have even in our daily OPD as well. So it is not just reproductive age group disorder, it masks beyond, it persists beyond the reproductive years. So the early adolescence and preconception age group, they are having more reproductive related clinical features like hirsutism, acne, infertility, menstrual irregularities. But as the age grows, it converts more into a metabolic sort of disorder, where obesity, type 2 diabetes, cardiovascular disease, those typical meds, they predominated the elderly group. So if you look at it, the risk of developing PCOS or the PCOS pathophysiology starts when a girl child is intrauterine. So just when the child is intrauterine, the genetic predisposition makes increase in the follicular count in intrauterine girl child, and they have a higher AMH and metabolic abnormalities from infancy itself. And there have been various studies studying this, but it's beyond the scope of today's discussion. So there have been theories where they have proposed androgen exposure in utero as a cause. Similarly, it persists in childhood and pre-pubertal age group as well. However, the diagnosis of PCOS in infancy and childhood is not possible. Only obesity can be one domain which we can gives us clue that the patient might be a future candidate for screening for PCOS. So these are the challenges when we get an adolescent child or a kid in which we want to suspect as PCOS, because as a part of normal pubertal changes, the patient may be having irregular cycles. The mid-luteal progesterone, which we usually do in case of adult or normal reproductive age group PCOS, is not possible in child. And the hyperandrogenic vision may be present otherwise also, like in normal puberty, acne may be present. But if a person is having severe cystic acne, it gives that the patient may be having more severe form of hyperandrogenism leading to PCOS. And the transabdominal ultrasound, which we just saw in Rotterdam criteria, is not helpful in diagnosing of PCOS in adolescent age group. So these are the criteria for PCOS in adolescents. If the patient is having persistent irregular menstrual cycle with clinical or biochemical hyperandrogenism, only these two criteria, both are mandatory, then only we should label the adolescent girl as a PCOS candidate. And the time of menarche is also very much variable in case of adolescents. So if the time of menarche is less than 1 year, you should not put a diagnosis of PCOS. If the menarchal age is like 1 to 3 years, then we should use the irregular cycles as less than 21 days or more than 45 days. Similarly, if the menarchal age is more than 3 years, then the cutoffs are less than 21 days and more than 25 days, or less than 8 cycles or year. Or if any time in 1 year, if a single cycle goes beyond 90 days, it's sufficient enough to call it as a candidate to screen for PCOS. So we'll keep it case based. So this is a case of a 16-year-old girl comes to you with weight gain, facial hair, acne, BMI of 29. So this is the modified FG score. I have not described. It was 8. We use it to classify hirsutism. So it falls into mild category. And the patient is having moderate inflammatory acne. Though investigation, they did an AMH, which was 11.9. So it is elevated, but in case of adolescent group, it has no role in diagnosis. Similarly, pelvic USG was not performed because transvaginal ultrasound is not possible in virgin female. Also, in this age group, there is no role of USG in diagnosis. So pediatric labeled as a probable PCOS. So the two learning lessons from this discussion is the diagnostic in terms of AMH is not useful, as well as ultrasound is not required before the gynecological age of 8 years. Gynecological age of 8 years means after menarche has started, for 8 years you should not use ultrasound for diagnosis. And the treatment is lifestyle modification, and SOS you can use metformin. If the diagnosis cannot be confirmed at this age, we can observe the patient closely until adulthood and reconsider if the features persist up till adulthood. So now in case of young women, the classical description has been in terms of hyperandrogenic features and reproductive concerns. And in those causes, the infertility is a very common cause of presentation in adult women, and pregnancy-related complication as well as metabolic disorder. So the classic phenotype, which was described by Steen and Leventhal, with obesity, hirsutism, amenorrhea, and bilateral enlarged polycystic ovaries, is seen usually in the reproductive age group women. However, it can be worsened in presence of obesity or overweight. So hyperandrogenic features are present in almost 60 to 80% of women in reproductive age group. So it has elevated total testosterone, free testosterone, available aldosterone and other indices of testosterone. So it is biochemical testing using testosterone is useful in this age group where you are suspecting PCOS, and the management is usually with OC pills, anti-androgens, and the local treatment for hirsutism. Similarly, menstrual irregularity is also predominant in this age group, and if menses are regular, then mid-luteal progesterone testing can be a useful parameter in those planning pregnancy and ovulation induction. So these are the classic ultrasound, which is diagnostic of PCO morphology on ultrasound, which consists of 12 or more follicles, each follicle being 2 to 9 millimeter per ovary and more than 10 ml without inclusion of dominant follicles. So these are the classical presentation of ultrasound in a PCOS female. So one more case I would like to, she is a doctor, 36-year-old, diagnosed with type 2 diabetes, with persistent acne and some facial hirsutism. And she had cycles every 45 to 60 days, and she had a weight gain of 55 to 6 kg over the past 2 years. Fasting plasma glucose 132, HbA1c of 6.9, BMI of around 30, and total testosterone was 78, which is above 60. And SHBG is low, 18. So low SHBG and increased testosterone, they go in favor of PCOS. So this is a common presentation in a physician clinic. So it's a classic phenotype A PCOS, which presented in terms of diabetes. So the patient would have had irregular menses previously, but we did not pick up earlier in her life. And so the management requires screening for any metabolic complications like MSLD, lipid profile, and OSS screening. And we can consider referral to endocrinology. So these are the phenotypic presentations of PCOS. The classic presentation, which is directly correlated with obesity, is called phenotype A, which consists of all three features, that is chronic anovulation, hyperandrogenism, and PCO morphology on an ultrasound. So obesity and metabolic syndrome are directly correlated with PCOS, and there is a bidirectional link between insulin resistance and hyperandrogenism. And the obesity is a classical factor deriving the phenotype of PCOS, and so lifestyle modification and weight management, which are the crucial issues in managing such PCOS occasion. And even moderate weight loss up to 5% can also help relieve the PCOS features. Additionally, we can offer anti-androgen or metformin. So one more case is presentation of a 38-year-old female with presence of increasing weight, easy fatigue, blood pressure of 140/90. Currently menses are regular, but she gives history that when she was 29 years old, she had undergone intrauterine insemination, and she does not have any acne or hirsutism at present. So looking at the first place, we might not think of even PCOS, but if you look at the biochemistry, she was pre-diabetic, LDL was elevated, BMI was obese, and HOMA-IR, which is a marker of insulin resistance, showed insulin resistance. So this is a case of a silent PCOS survivor who has had PCOS initially, but never attended, now presenting with evolving metabolic complication. So she also needs full-time screening for full-time metabolic screening in terms of diabetes, MSLD, lipids, and blood pressure, weight reduction, and cardiovascular risk reduction. So PCOS does not end when the periods normalize. It evolves into a metabolic disease eventually. So metabolic monitoring and care is an essential component of managing PCOS. And the treatment in terms of OC pills is often effective, but we have to look for obstructive sleep apnea, MASLD, and treat accordingly. And they are also prone to other vascular complications, just like any other metabolic syndrome patients. And while treating with OC pills, thromboembolic risk needs to be considered. And metformin can be offered if the patient is pre-diabetic or diabetic. Also, there are psychological areas to be addressed. The patient may be having low self-esteem, depression, and anxiety, and eating disorders are common in such females, and it interferes in our capacity to offer lifestyle management to the patient. Hence, it is important to address the psychological parameter as well. So next, this is a case of a 34-year-old female. The patient has been trying for pregnancy for 2 years, presented with subfertility. Patient is not able to conceive. Menstrual cycle is every 35 to 40 days. Mild persistent acne is there since she was teenage group. No weight gain or hirsutism. So on evaluation, her testosterone was found to be 68, which is above 60. SHBG was on the lower side, and free androgen index was elevated. LH-FSH ratio was more than 2:1, and other hormonal parameters were normal. So this is classical description of PCOS. So it was a case of missed PCOS, which otherwise would have been there. The important learning point is there. If you look at this patient's BMI, the patient was very lean actually. So this is a very classic lean phenotype of PCOS. Just like we have got a subgroup of lean type 2 diabetes, similarly there is a subgroup of lean PCOS also. The patient will have menstrual irregularity as well as hyperandrogenism, but there will not be any component of obesity. So first is to offer lifestyle modification as well as go for fertility support in terms of whatever the options are available, and they also have equal metabolic risk. So metabolic risk assessment is also important in such group of females. Lastly, in the menopausal group, there is a usual decline in the ovarian and adrenal function with aging, and this leads to regularization of the cycle followed by discontinuation of the cycle, and they have a longer reproductive life compared to those without PCOS. So another challenging subgroup is postmenopausal female. We'll discuss in detail. So the diagnosis of PCOS in perimenopausal women is considered when there is a past diagnosis of PCOS or a long-term previous history of irregular cycle or hyperandrogenism or PCOS morphology on ultrasound during the reproductive years. However, if there is a new onset hyperandrogenism which develops during the menopausal period, we should consider other androgen secreting tumors first, then label it as PCOS. So one more case I'll present. Mrs. D, who is 45-year-old, recently diagnosed with type 2 diabetes, ultrasound shows fatty liver, MASLD, central obesity with borderline hypertension. The patient reveals history of irregular cycles during her youth, which was treated with ocipils at that point of time. Patient conceived both children via ovulation induction. The patient is postmenopausal for 2 years. She has depressive features, A1C of 72, altered ALT, maybe because of MASLD, elevated triglyceride, and BMI of 33. So this is a case of unrecognized PCOS in youth, which she underwent ovulatory treatment, and now she has developed full-blown metabolic syndrome, and she needs comprehensive risk management for severe risk profiling as well as lifestyle modification and pharmacological intervention. So metabolic syndrome at 45 may be echo of missed PCOS at 25. Last case for today's discussion is 53-year-old female presenting with increased abdominal girth, daytime fatigue and poor sleep quality. This may be feature of obstructive sleep apnea. She has already had hypertension and type 2 diabetes. History reveals she is menopausal since the age of 50. Previously, she was hirsute and had ovulation induction for pregnancy. HbA1c is 7.8, LDL elevated, waist circumference 106, and BMI of 34. So this is also a classical feature of PCOS. So the PCOS features have vanished. However, the risk often amplify after menopause, and she also needs glycemic and lipid control, management for her OSA and fatty liver, as well as metabolic surveillance. So the PCOS does not retire even after the reproductive age group. The metabolic and long-term health risk take precedence. So there is a need for continuous screening of the metabolic risk, and lifestyle modification should be given to all such group of patients even without PCOS symptom at present. So last few slides, why PCOS matter to every physician. Just as I said just 15 minutes back, why we are discussing PCOS in a physician forum. So a PCOS patient may be a common visitor in every physician's OPD, often undiagnosed, misdiagnosed, or outgrown symptomatically, presenting as a patient with obesity or metabolic syndrome. But the primary PCOS which the patient would have started from initial intrauterine life may have outgrown and led to the metabolic complications. So PCOS spans the life cycle of a woman from in utero to the end of life, and there is a high prevalence of insulin resistance, prediabetes and type 2 diabetes, dyslipidemia, fatty liver, and hypertension in patients with PCOS at any given age group. Hence, the patient may be presenting in a physician OPD just in disguise as an obese female. The patient would have underlying PCOS. Sometimes the patient would have had psychological concerns like anxiety, depression. The patient would have menstrual irregularities, which is a common history we take as a physician OPD as well. But sometimes we may miss the diagnosis of PCOS. So PCOS symptoms often surface in medicine clinic before they are labeled as endocrine. Lastly, the risk of metabolic disorder persists beyond the reproductive age group. So even if the cycles have regularized, the patient is not obese, the patient is lean, but just the presence of previous PCOS renders the patient higher risk for type 2 diabetes, metabolic syndrome, cardiovascular disease, and endometrial cancer. Hence, it is mandatory to spot the early signs in the adolescent age group as well as early reproductive age group, and refer timely for fertility, cosmetics, and other advanced endocrine evaluation. So just what we discussed in single slide, the risks of PCOS starts from intrauterine to childhood in terms of various disorders, to adolescence, to reproductive years in terms of infertility, menstrual irregularities and metabolic syndrome, as well as menopausal and postmenopausal women in terms of cardiovascular disease, type 2 diabetes and metabolic syndrome. To summarize, top 5 pulse from today's lesson. Remember, we are having a very good quiz at the end of this session. So every topic what we discuss will be having some questions. So maybe we may get one question from our discussion as well. So in adolescents, the criteria are very stringent. There is no utility of AMH or ultrasound in diagnosing PCOS in adolescent age group. In adults, we can consider PCOS even in lean or those whom otherwise we would not have considered as having PCOS because obesity is absent. And once we pick up a case, it's mandatory or it's prudent to treat them early in terms of lifestyle modification as well as pharmacotherapy if required, so that the symptomatic relief is given, fertility issues are addressed, as well as long-term metabolic risk can be reduced in terms of diabetes, MASLD, as well as cardiovascular disease. So PCOS is not just a reproductive issue. You have to continue monitoring for type 2 diabetes, fatty liver, metabolic syndrome and CVD, even beyond the fertility years, as well as mental health concerns like anxiety and depression and imaging issues are common that need to be taken care of. And always screen the patient for metabolic risk, especially glucose, lipids, blood pressure and fatty liver. And referral to an endocrinology may be required when you are considering other secondary causes of PCOS. I think that summarizes my talk. Thank you so much.